που τα μάθατε όλα για τους αεραγωγούς, λίγα πράγματα για ένα πιο δευτερεύον και μη σημαντικό θέμα, τις παρεγχηματικές διάμεσες πνευμονοπάθειες. Έχω τη χαρά να συμπροεδρεύω με τον κύριο Πολυχρονόπουλο. Έχουμε δύο πολύ καλές μικρόφωνο. Καλά, δεν είμαι και τραγουδιστής, το λέω. Λοιπόν, μεγάλη τιμή που έχουμε μαζί μας τη φίλη μας καθηγήτρια από την Ιταλία, την κυρία Σάρα Tomassetti, η οποία ασχολείται ιδιαίτερα με τα διάμεσα πνευμονοπάθεια, συμμετέχουν πολύ στα διεθνή φόρα. Σάρα, welcome to Greece, welcome to Θεσσαλονίκη. Θα μιλήσει Ιταλικά, αγγλικά όπως καταλαβαίνετε. Latest developments in diagnosis and treatment of ILD. You can speak also in Italian because we have many.
Yeah. Kalispera to everybody, and thank you very much to the organizers, to my chairs, and to the sponsor. I'm truly honored to be a speaker in your National Congress. And the topic is really interesting and is about innovation and all news in treatment and diagnosis of interstitial lung diseases. I have basically split the presentation in two parts. The first is on diagnosis, and of course there is a lot, and I had to choose some topics. So I basically focused on interventional pulmonology, which has been my field of research for many years, and a couple of guidelines that have just been released. For interventional pulmonology, I believe that cryobiopsy has been the most important innovation in the last 10 years, and I want to thank all the Greek friends that participated in the transbronchial cryobiopsy course and made it very enjoyable in the last 2 days. The story started in 2009 with Jürgen Hetzel publishing the first report of cases diagnosed of interstitial lung disease diagnosed using cryobiopsy. And then several authors, including Venerino Poletti, who I worked with for many years, have published several studies. We focused on the prognostic value, comparison with surgery, the impact on MDT diagnosis, and finally, in 2022, it ended up with endorsement of the ERS for cryobiopsy use for the diagnosis of interstitial lung disease. And basically, this technique has an accuracy that falls short to that of surgery, but with a better safety profile. And the only trial that I really want to share with you is a trial that has been published last year in Lancet Respiratory Medicine from the group of Anema, who compared a straightforward approach to surgery to a stepwise approach, cryobiopsy first, and then eventually surgery only in cases where cryobiopsy is non-diagnostic. The primary endpoint was safety and was comparing unexpected chest tube in the cryo arm versus persistent nerve leak in the surgery arm, and it was met. So cryo was safer compared to the straightforward surgical approach, but there are several other secondary endpoints that were pre-specified, very important, and all were met. First of all, if we use the sequential approach or the straight-to-surgery approach, we have the same diagnostic yield, which is 90%, but with the sequential approach, we have a significantly better safety profile. So this is the first and the only randomized trial that has basically shown that cryobiopsy should be the first step because it gives us the same diagnostic rate, but with a better safety profile and a lower patient burden. This basically gives more strength to the recommendation of the guideline that already endorsed this approach. But in the future, we may have a lot less diagnostic method. And in interventional pulmonology, the method that I want to show you are two different tools that allows in vivo microimaging of the lung. The first is the probe-based confocal laser endomicroscopy. We choose a laser-based imaging technique and allows imaging in vivo with a resolution of 3.5 micrometers. So you can recognize the interstitium and the cells in it. It is non-invasive, doesn't expose the patient to radiation. It is very quick, and it can be repeated over time. And here are the imaging and pathologic correlation. It has also been used to guide cryobiopsy, showing that can increase the diagnostic cure rate, decrease operation time, and significantly decrease the complication. Even more intriguing is the optical coherence tomography, which has been recently upgraded to polarization sensitive OCT. This technique has a resolution around 10 micrometers and basically give us images that mirror those of the histopathology, has the same technical characteristic of the previous one, but doesn't use laser, it uses near infrared waves. The polarization technique also gives us quantitation of fibrosis. So with this technique, we can recognize imaging patterns that resemble IPF-UIP, fibrotic HP, NSIP, and many others. And with the polarization technique, we can also quantify in this color-based scale the presence of fibrotic tissue. Now, moving to more clinical relevant news, there are a couple of guidelines that have been just recently released. The first one is on interstitial lung abnormality. It comes basically from the States. It's an ATS guidelines. And compared to the previous definition of ILA, it changes a little, at least 3 major things. So the first one, ILA for the Fleischner definition had to be incidental to be defined as ILA. Now with this guideline, these have been removed. So any interstitial lung changes, even if in population at risk, will be now classified as ILA. Second, and this is very important, and we will see another slide on it, this is the first document that sets criteria to distinguish ILA from ILD. So what is just radiologic changes compared to what is a disease. And finally, they give screening suggestion, basically assessing ILA on imaging done for lung cancer screening, screen all CTD and familial ILD, and monitor at least every 2 or 3 years are the major indication. We will briefly see some of the detail. I believe this is the most important message, how to distinguish the disease from ILA. There are some clinical criteria. So if there is any, even trivial, physiologic impairment or clinical changes in symptoms, this should be called interstitial lung disease. If there is progression, either defined using the PPF criteria or even only CT progression of the fibrotic abnormalities alone, then this should be defined as interstitial lung disease and not ILA. And again, if there are clear morphologic criteria of major fibrotic patterns, including UIP, probable UIP, fibrotic NSIP, or fibrotic HP, again, these should be classified as ILD and not as ILA. So for monitoring and screening, the indications are quite clear. We should consider ILA, and radiologists should report it in the population that undergoes lung cancer screening. We should screen all CTD and all first-degree relative of familial cases. Incident cases of ILA should undergo a risk assessment, symptoms assessment, and pulmonary function assessment to define whether it is an ILD or an ILA. and of course, counseling for the risk reduction for interstitial lung diseases factor risks. For prevalent ILA, then the follow-up recommends, if there are individuals at high risk, follow-up with the pulmonary function test and HRCT at least every year, and if they are at low risk, every 2 or 3 years. And of course, there is a list, and we will not go through it of the all risk factors, which is detailed in the document. The second guideline, this is another very important document that comes from ERS and Euler. So it is a combined pulmonologist and rheumatologist guideline for ILD diagnosis, monitoring, treatment, and screening. It has not been published yet, and I really want to heartily thank Professor Caterina Antonio, who was the chair of this guideline and who allowed me to use her slides. So there are 4 major points that are reported in the guidelines. First of all, appropriate screening tool, and just to make a long story very short, the recommendation is that we should use HRCT for screening. We should screen all CTD with the exception of rheumatoid arthritis and Sjögren. There should be screened only in patients at risk. And again, the guideline gives us a lot of details on how to define risk factor for ILDs in this heterogeneous population. At diagnosis, the assessment includes the tests that we all know very well, HRCT, lung function with 6-minute walking test, and patient outcome reported. BAL and lung biopsy are reserved only to exclude malignancy or infection, but I believe that really there is an unmet need, at least on the research, from a research point of view, because we know very well that the data on the utility of histopathologic information in CTD-ILD are scanty. Probably the best study was published by Bourros and Arthur Wells in 2002, and all the studies are small, underdimensioned, and on surgical lung biopsy. So now that we have more potent tool and less for the analysis of the tissue and less invasive technique, we should probably, at least from a research point of view, try to have a different view on the utility of lung biopsy. Moving to the next topic on the guidelines, monitoring. So monitoring tools are, again, both functional and HRCT. The frequency varies depending on the specific CTD diagnosis, on the risk of progression, high or low, and on disease duration. And we will not review in details all the algorithms, which are quite complicated, but this is just to show you that for each disease, you basically stratify individuals at high risk, low risk, short or long disease duration since diagnosis, and then for each test, you find different timing based on these population characteristics. In terms of treatment, nothing strikingly new from the guideline. Basically, first line for CTD-ILD remains immunosuppression, and then nintedanib may be chosen as an additional option in systemic sclerosis. The usual recommendation against high doses of corticosteroids in systemic sclerosis. And for progressive form of CTD-ILD, nintedanib, it finds an indication in all this group, and this is based on the inbuilt data mainly, and pirfenidone in rheumatoid arthritis with UIP based on TRAIL-1 data mainly. But the real news about treatment come from the recent Fibroneer trial, of course, which evaluated the safety and efficacy of nerandomilast for both IPF and PPF. So we will briefly review the nerandomilast trial results. Basically for IPF, the study design is really similar, 52 weeks trial with a second database lock that was at a longer follow-up time that was possible due to the very early enrollment of patients in the early phase of the trial. We have to remember that compared to all trial, we now have a placebo arm in which we have both patients that are naive and patients that are already treated with antifibrotics. The population is a population with a long disease duration, more than 5 years, FVC and DLCO around 78 and 50%, with some difference between who is taking background antifibrotic and who is not, because patients on antifibrotic have a longer disease duration and a higher use of supplemental oxygen. But in terms of results, the drug clearly show an effect both in the general population that was statistically significant in the reduction of FVC decline of 52 weeks, even more pronounced if we look at the subgroup of patients without background therapy, meaning that we can use nerandomilast in naive patients at both doses because they are both equally effective. And we can also use nerandomilast at both doses on top of nintedanib, and the data shows an advantage with this combination therapy. With pirfenidone, the news was that the trial discovered an interaction between pirfenidone and nerandomilast. Pirfenidone reduces this bioavailability of the drug, and so if we use low doses of nerandomilast, basically we lose the effect. And the only way to have some effect of nerandomilast when combined to pirfenidone is to use the 18 milligram dose. The curves separate nicely early at 26 weeks, and the effect is maintained or apparently even increased with a longer follow-up duration, so at 76 weeks. This is the first trial that shows a numerical advantage in terms of mortality reduction, and also this drug shows a very safe profile. Expected possible events related to class effects, particularly psychiatric events and vasculitis and cardiac events and other, were equal to placebo. And diarrhea, which is one of the most common adverse events that we have to handle, actually was only slightly increased compared to placebo using nerandomilast alone, a little bit more using nerandomilast in combination with nintedanib. But again, these are numbers that are not superior to what we have seen for nintedanib in the past for the combination, and significantly better for the use of nerandomilast alone. The PPF trial, very few slides, same study design, different population that was selected using the inbuilt criteria. These criteria select a very specific population because these are cases of fibrotic ILD that progress despite treatment, and you end up having a population which is non-UIP but still highly, non-UIP IPF, but still highly enriched in UIP that radiologically was 71%. And we don't know how many were histopathological UIP in the remaining 30%. Again, a quite long duration of disease, 4 years, and 1/3 of cases of patients using supplemental oxygen. 1/3 of the cases were autoimmune disease. the drug effect was significant at both doses in the general population. The effect is maintained in monotherapy and in combination therapy with nintedanib as background. Interestingly, here the curves separate even earlier and stay nicely separated through all the entire duration of the trial. The effect on mortality is even a little bit higher compared to the IPF trial, and the effect on diarrhea is significantly lower. If we use nerandomilast at 9 milligram in this population, we have no diarrhea. I mean, we have the same prevalence of diarrhea as the placebo arm. This increase if you combine it with nintedanib and particularly increasing the dose of nerandomilast and combining it with nintedanib. And for the last 30 seconds, I just want to reach my conclusions. So I've basically focused the attention on cryobiopsy that has now really become the first line approach for tissue sampling in interstitial lung disease. I've shown a couple of emerging tools that potentially could provide clinicians with in vivo microimaging of the lung in the future, avoiding the need of biopsy. New guidelines, the first one on interstitial lung abnormalities that most notably in the get rid of the incidental in the definition and introduce new criteria to discriminate ILA from ILD, including histopathology. And the new CTD-ILD guidelines that define a tailored approach for monitoring, follow-up, and of course treatment remains on nintedanib for most of the progressive form, but the news on treatment comes from the two trials that shows that nerandomilast is effective in both entity, IPF and PPF, with a very good safety profile. Thank you very much for your attention.
Thank you very much, Sarah, for the nice overview.
Thank you.
Of course, the transbronchial cryobiopsy based on the work of Venerino is highly recommended as a first diagnostic treatment instead of VATS. And as we expecting the third antifibrotic drug, nerandomilast, I'm very happy because 2011, I written an editorial in Lancet stating that oncologic approach is the way to go. And now we see that this kind of combination has better results than the one. Question from the Argyris?
Argyris.
Short question. Because
Sarah, thank you for your great talk. Always very challenging cases that you are presenting. So regarding the ILAs, I have many questions, but just a simple and short question. Do you think, like, before getting into the risk stratification based on the age, based on the history, based on the exposures, we should also integrate genetic risk factors like MAC5B? It's just a simple PCR, because like if you have MAC5B mutation, you have ILA 7 times higher that you're going to progress within the next 3 years. I mean,
yeah, I agree with you. I mean, the guidelines do not really encourage doing genetic testing, but in the sense that the genetic testing should not replace HRCT, which makes a lot of sense. But once that you have fibrotic changes, even if minimal, I agree with you that genetic can give a lot of information. Yes. Thank you. Very important comment.
Very short question.
Very, very short. Thank you, Sarah, for the nice overview. What is your thoughts about the early separation in the PPF group, which is maintained very, very, maybe also showing this effect on survival for the first time, taking in consideration that those patients, at least for 6 months, they didn't take any kind of immunosuppression like MMF, etc.
Yes.
Just your thoughts. Thank you so much.
Thank you, Katerina. This is another very important point. So we know that nerandomilast has at least double effect, so anti-inflammatory and anti-fibrotic, and it has really different cellular targets, epithelial cells, endothelial cells, which are under further investigations, inflammatory cells, and fibroblasts. So it could be that the early effects rests more on the immunomodulating anti-inflammatory effect rather than on the anti-fibrotic effect. And these are data that we really need to accumulate with further research. Thank you so much for the question.
Okay, thank you very much. We don't have time for another question. We have to pass
Sorry,
the break.
George. Thanks.
So the next presenter.